Off our webinar today, we're talking about technology for improved LTAC wound management, and our speaker who will be joining us today is Jennifer Wallace, who's the CEO of AMG. AMG is part of a larger organization with, I understand now, 19 facilities in the long-term acute care space operating across the United States. And Jennifer has a dual role, as we will explaining about her in a moment. So as I've already said, she's the CEO of this facility, but she has a secondary role as well, as she's the corporate director of quality. And I can see now that our slides are outdated as AMG opened up their 19th facility yesterday. Jennifer's particular facility, as you can see, has 40 beds, and you're probably aware in the LTAC setting, a great deal of the patients there suffer from wounds, whether they be traumatic or pressure-related or chronic or in other means. But despite if you're not from the LTAC background, a great deal of the information we'll be speaking about today is readily transferable to other care settings. And in particular, there's a great deal to learn from AMG, as they're really a good model of interdisciplinary team support when it comes to patient care, and particularly in wound care. So a few words about me. I am a moderator for this event, and I'm also an industry consultant working in the long-term care and in the wound care space. What we do today is quickly go over today's agenda before we turn this over to Jennifer. So today our agenda is about technology for improving wound management. We'll be talking about this from the LTAC setting perspective. And we'll start first, which in the most important area, obviously, is how we get great clinical results in treating patients with wounds. And then we will go on to talk about how this impacts the nursing organization, particularly in the nursing time and the streamlining of the workflow that nurses encounter as they work at AMG in a wound management system. And then we'll be discussing the economic impact to the wound management system at the AMG facility, and wrapping up with a case study. After that, we'll go to Q&A. So without further ado, what I'd like to do now is turn this webinar over to Jennifer Wallace, the CEO of AMG Greenwood. Ask her to talk a little bit about her organization and what it was like before they implemented a wound management system. With that, I'll ask Jennifer to please take it away.
Thanks, Deb. I appreciate this opportunity. I wanted to start by just giving you a little background on AMG's previous experience with wound management. The LTACs began reporting pressure ulcers to CMS back in October of 2012. And when this occurred, it really opened our company's eyes to the many issues that we had with our wound documentation. There were issues with data validity, poor and even worse at times, no documentation, time-consuming assessments, if they were done correctly, time-consuming quality data collection. We found that our facilities were using a variety of forms, a variety of methods for our wound care documentation. We also found that many of our wound care nurses were logging quite a bit of overtime, just trying to stay even partially caught up with the documentation, the pictures, assessments, printing up pictures, calculating quality data, and etc. Our coders were having to spend way too much time querying wound care documentation due to the conflicting information from staff and physicians. And we were trying to find a way to standardize this process and make it easier for our clinicians. And we wanted to drastically improve our documentation. We had to. We began looking at various options, and we finally decided to try out WoundRounds. So in the fall of 2013, our company decided to trial 2 facilities, and it was later rolled out to all the others in spring of 2014. The most important key for us was the documentation. The documentation is important and actually vital in order to support the level of service, to support the frequency and the type of treatment, to support preventative interventions, and to support determination of unavoidable pressure ulcers. We recognize the value of WoundRounds in enabling our care teams to improve patient care and to also provide more proactive and preventive wound care. we felt that WoundRounds would provide the standardization and the streamlining of wound care across all of our facilities. The basic premise is simple. Nurses use a mobile device at the bedside to capture the patient's clinical picture. The data and images are then uploaded to our secure servers, and from there, users can print the documentation and reports in real time. Which, by the way, I have to say, those reports were one of the major selling points of WoundRounds for me, and you'll hear me brag about those often. Looking at our documentation prior to WoundRounds, the nurses were using, like I said, a variety of forms. They were utilizing multiple different brands of cameras, picture formats. Pictures were printed out in a variety of ways, unfortunately, sometimes not even in color. And because of the time-consuming printing methods, documentation many times wouldn't even make it to the chart in a timely manner, which further delayed treatment changes at times, and it certainly frustrated our physicians. Frequently, the push-tool scores on patients were not being figured or trended until the end of the month rather than on a concurrent basis. The Braden scale was just something that had to be completed in the nurse's notes, and I'm not sure that even half of the nurses really understood what the purpose of even documenting that was for. And the reporting of the data required manual computation, and it took several hours to complete. Once we switched to WoundRounds, we saw the nurses are able to perform and complete their assessments all at the point of care. The prompts for the data collection are all based on national standards of care, such as the WOCN, and the documentation is electronic and may be printed on demand and in real time. The treatments are better documented. They all line up with a facility formulary, which is as an added bonus, at the corporate level, we are able to better monitor the use of our non-formulary items. Then on to the reports that I love so much. The risk reports give us an instant snapshot of who our most at-risk patients are simply by running a report. We also can generate reports that look at Braden score trends and push-tool score trending. Also, one of the best features for us, certainly a selling point, was the Section M report, which automated our wound information that is entered into the care data sets. And the care data sets for the LTACs are comparable to the MDS for the skilled facilities or the IRF-PI for the rehabs. And our people that were entering the care data sets into the computer, they simply press a button, it generates the Section M report, and gives them the exact information in the exact format that is needed to complete that section of the care data sets. Utilizing all these reports has significantly improved the time spent figuring our quality data as well. The wound care management process, as you can see, can be rather complex, and this technology can help manage some of that complexity. On admission, each patient has a risk assessment for wounds completed, and prevention of any wounds is planned. If the wounds are found, you enter in a wound assessment, and then it provides structured documentation. Our treatment plans are completed using a pre-programmed template, and evidence-based and validated tools are used to monitor the outcomes. We have dashboard alerts, and we have reminders that keep us up to date and proactive with our documentation. And then finally, on the back end, we have outcomes that are reported via the care data sets and through our QA reporting. So in the beginning of this implementation, we actually at AMG, we did see a spike in the pressure ulcers as the staff became more involved with assessing and identifying these hospital-acquired wounds. All of a sudden, there was a spotlight on the assessments of wounds, and we saw a big change with that. Just a couple of months after implementation, though, we did begin to see a large decline in those numbers, thank goodness. We're now confident in the validity of our quality data when we're reporting on wounds. We also developed a policy where patients are now routinely assessed upon the day of the admission. Photographs, measurements, and other wound details are recorded at the same time. There is now better consistency among staff in differentiating wounds, such as pressure ulcers, from other wounds with similar appearance, such as venous stasis ulcers. And also the wound descriptions and the treatment notes are finally now complete and with accurate detail, as opposed to getting very little or even no description of the wound. As I mentioned, the mini reports, they give us a better managerial oversight on clinical care. It gives us the opportunity to be proactive rather than reactive, and we've certainly been able to catch trends and issues much faster than we ever used to. I'm going to share just a few examples of what we are now seeing with WoundRounds that we, again, certainly never saw before in our documentation. On this slide, this is an example of some of the pictures that were taken using that same PDA device. Again, with the PDA device, you put in your clinical picture, and it's also your camera. As you can see, they're very clear, and it's very easy to monitor progress and the response to our treatment plan. We can easily do a side-by-side comparison of pictures over a period of time, and we can tell from a really quick glance at those reports how well we're doing versus digging through mounds and mounds of paper to find these photos, put them together, and who knows if the photos are even there. This is an example of a wound assessment, and this is one of my favorite things as well. You can see all of the detail that goes into this wound assessment. Compare this, what you see, to just the one or two sentences that you might normally get in the chart. There's really no comparison, I know certainly with us. From this one assessment, I can see what kind of wound it is, the date it was identified, if it is a community or facility acquired, the push tool score and the trend, and all of the assessment details you would possibly need. The tissue type, including the percentages, your exudate, peri-wound information, odor, infection, pain, dressing present. I can also see detailed information on the measurements. There's also a prompt towards the end of the assessment where you enter in your current plan and then any kind of comments. The system does prompt you to complete all these sections, which thankfully prevents an inadvertent omission of information. Besides looking at this photo, the documentation gives me a much better clinical picture of what is actually going on with the patient. If I were to just read the details, I could pretty much picture the wound before I even looked at the picture. By documenting all this at the bedside, I can capture all this vital information as I see it. There's no more going back to the nurse's station, waiting several hours in the shift, and then trying to remember what all you saw and all those many details. Now I can do it all at the bedside. I know the wound information is captured correctly, and all I have to do is print and sign. This slide is just another example of one of the ways that we can easily monitor healing. It's one of the many reports that I've bragged on. This is a trend report that shows what my push score is trending. This level of detail is actually very helpful when you're as busy as I know I am, and I know all of you are. It's very easy to quickly look and see what's going on. And very quickly, we can see that the push score is going down, which actually means that the wound is improving. If we were to see the graph line going in the other direction, we would be able to tell very quickly that the wound is not improving, and we need to possibly look back and change some of our interventions or some of our treatments. Very quick glance. Another favorite, the risk trends. As I've mentioned, we want to try to be as proactive as possible when dealing with wounds. Our policy requires that the Braden scale is entered every single day on every single patient, regardless of whether they have a current wound or not. And as you know, the Braden scale tells us how at risk a patient is for developing pressure ulcers. And as I'm sure you know, again, the Braden score works opposite of the push score. According to the Braden scale, the higher the score, the less the risk. The lower the score, the more at risk. The slide that you see before you is just another example of how easily we can get this information by just the click of a button. This report shows in red anything that is scored as a major problem. It lets us know where to focus our treatment plans, such as mobility or moisture issues. And on this example, as you can see at the top, the patient's activity of being chair fast is certainly an issue. So by glancing at this risk report, we know that we should be putting measures in place with this patient to prevent sores while they're in a chair. Maybe we need to look at some cushion, certainly frequent changes of positions, and some various other interventions. So very soon after implementing WoundRounds, we asked our charge nurses to run the risk reports for the patients on the floor or unit that day in order to more closely supervise the turning and repositioning of the patients that were at the highest risk for developing pressure ulcers. These were the patients that we really needed to focus on. We needed to make sure we were utilizing those heel protectors, wedges, and anything else that may be utilized to prevent breakdown. It's so much easier to identify these patients by just running a simple risk report rather than digging through those days and days of notes in a patient's chart. And here at this particular facility, we recently hired a wound care tech that has a variety of things that she does do, but in addition, she assists the wound care nurse with treatments, and one of her very specific functions is to run this daily Braden score, and then she is to round daily on those that have those critical Braden scores in order to verify that the proper interventions are being used. And so far, it's been very successful. So the next thing I want to discuss is how WoundRounds affected our nursing department. It certainly helped to decrease nursing overtime and streamline the flow. This slide is the example of our nursing time savings. It's a quick snapshot of a time saving study that our company did not long after we first implemented the product. The items on the left-hand column are items that we had identified as being the most time-consuming portions of the wound care's time. We found that on average, calculating push-tool scores and the differences each month for quality reporting on all of the patients took approximately 5 hours prior to WoundRounds. After implementation, it went to 0 because we were able to obtain this information immediately with just the click of a button. It saved us 5 hours a month just on those things. For the LTAC care data documentation, again, which is similar to your MDS or your IRF-PI, we spent approximately 5 hours a month working on care data documentation. After implementation, 30 minutes. We were able to create the report that replicated exactly what was on the care data sets in just a couple seconds. But it did take just a couple minutes to input that data into our system in order to be submitted. For quality data gathering, 5 hours before, only 1 hour, that saved us 4. Wound care photo documentation and printing used to take around 10 hours, now takes maybe 1, and that saves us at least 9 hours. And then the two biggest time hogs, if you will, were the initial documentation of wound care measurements and then the reassessments. Both of these things were cut completely in half. All total, we found that after the implementation of WoundRounds, it saved our nursing team approximately 55.5 hours per month. And for us, it represented a yearly amount of around $20,600 per facility. This was based on the wound care nurse's pay. And if you multiply that, at the time, it was over 15 facilities, we saw that our company could potentially save somewhere around $300,000 annually just in this small area. This represented a 65% time savings on wound care activities. And I know for us at the managerial level, that was certainly a significant improvement. The next item on the agenda involves another study that we did, and this one was at one of our Louisiana facilities involving our labor costs. This slide encompasses another quick snapshot of what we saw from the payroll perspective. When we first started diving down into the numbers and the processes prior to WoundRounds, we found that almost every wound care nurse was struggling very hard to get their work done in a normal 40-hour week. Many were working significant amounts of overtime just to get the basics done, just to get those assessments and the documentation complete and just on the medical record. We did find that several were very dissatisfied with their job. They spent a lot of time on the job and they had constant late hours. So after implementation, we wanted to see what our possible return on investment was. And we found that we had actually cut payroll spending and total number of hours when we compared the data from year to year, as you can see from the slide. And if you are wondering, we did compare the amount of wound care patients during that time period just to see if there had been a decrease in wound care patients or types of wounds that may have possibly caused those decrease in amounts. And what we found was not only was there not a decrease, there was actually a slight increase in patients and wounds during that period. I do want to throw out that no one got laid off or lost their full-time hours, but it did simply decrease the large amounts of overtime that they were working. And we also felt like many of the wound care nurses' satisfaction increased due to being able to actually complete their work in a normal shift. And they also had more time now to be, again, more proactive rather than just reactive and having to do just anything that popped up. So last on the agenda, just a quick glance of a typical case. This is an actual case study from another facility, but it's very, very typical of the things that we see. The assessment details tell us exactly what we saw, and the ease of the assessment at the bedside made things go so much smoother. You can see on this slide, you can see from the graph that he showed marked and continued improvement over a period of time. And on this, as you can see, his risk profile identified poor nutrition as a significant problem, right up there in the red. His nutritional status was closely monitored, and with dietitian's input, the patient's nutritional status did begin to improve. However, if you will notice on the Braden graph, there was a big decrease in the Braden score, which is indicative of an issue. The patient went from very limited risk to all of a sudden being high risk for developing ulcers. And in this particular instance, the patient's incontinence had increased. The patient was assessed more closely, and he was found to have developed a UTI. This was caught much quicker than it would have been if this tracking and trending had not been being utilized. This was a good outcome. And without the tools, it might have been a good bit more challenging to get this outcome. So overall, WoundRounds had a huge impact for AMG in a variety of areas. From the clinical perspective, we found that improved monitoring and tracking of a wound status over time improved our quality. We did show a reduction in our facility-acquired pressure ulcers, and we did see a huge difference in our documentation. We actually now have more consistent and accurate documentation. We also saw that we were able to provide much more effective managerial oversight, and my time wasn't wasted trying to dig through huge patient charts just to get very little patient information. From the nursing time and payroll perspective, we certainly found that automated charting and reporting definitely saved us time, and that a more streamlined workflow also produces a time savings, and so in turn, you're going to see payroll savings. From the risk perspective, we have seen that our complete and accurate documentation drastically minimizes risk. And I actually had an attorney recently, I was reviewing one of our charts, and he told me that this was actually some of the best documentation that he had seen in a patient's chart. And moving on, we actually were able to have this particular case, it was dropped because our documentation was so thorough. And of course, obviously that's a huge benefit. We've also had a lot of great success with surveys. And this was directly related to the documentation in WoundRounds, from Joint Commission to our Department of Health surveys. We've seen a big, huge improvement. Everything the surveyor was looking for was right there, from the history of the wound, information about wound improvement, and even those Braden scores for risk. Finally, from the financial return on investment perspective, we saw a lower cost of treating wounds. We see that we're able to heal them faster, prevent more, and also have an opportunity for increased patient census. So because I have a passion for healthcare quality, as Deb mentioned, I am the Director of Quality. I do tend to think more towards the quality side of things, and I really think, I like to think that it's not all about the technology and what it can do for us. It's more about the quality of care we're given. So I do like this quote. It's improving wound care is a quality initiative and not an information technology initiative, and we firmly believe that here. So I thank you all for your time, and if there's any questions, please let me know.
Well, Jennifer, thank you so much for doing an excellent job today of sharing the results and the insights that you've gained along the way from working in wound care at AMG. I don't know about you, but that was quite an education for me, for everyone on the line. I hope that you enjoyed what Jennifer had to say today and got some pearls from it for yourself and for your facility. Before we go into Q&A, I did want to thank our sponsor, which is, of course, WoundRounds. And if you don't know already, WoundRounds is a point-of-care wound management and prevention solution. And you can find out more about it by emailing us or by reaching out after today's call. What I'd like to do right now is open up the floor to questions. I know that some have been typing in on the dashboard on the right-hand side. So we've got a couple questions that we'd like to ask Jennifer. And the first of which, this is a good one, is Jennifer, if you could share with us how your management system interfaces with your electronic medical record.
Well, the LTACs didn't receive incentive payments to get an EMR, and at this point in time, our company doesn't have an EMR. So actually, WoundRounds was really our first foray into an EMR, if you will. We had a few very small bumps. Mostly it was our staff just adjusting to things, but overall it went remarkably well. And to be honest, I can only hope that when and if we do transition to a full EMR in the near future, my only hope would be that it would go as well as when we transition to WoundRounds.
Wow, so there has been some questions about the implementation process as well. Could you maybe share with us what was the learning curve like, particularly for your clinical team as they brought this wound management system online?
Well, I could talk for days on that one. And again, my email is up there, and I'm more than happy to answer any questions that you may have. For us, it was fairly easy and painless. It was well organized in advance, and that certainly did help. We were sent an IT spreadsheet and another implementation spreadsheet that outlined exactly what would happen, so everybody knew. But the best part for us, I think, was that the educator came out, and she educated the staff and us, and it helped to get the in-house patients admitted to the system for us, and that was done by the educator, and it got us rolling. Our nurses, they really embraced it at that point. They were able to ask a lot of those front-end questions, and that certainly helped. Then also, of course, the staff has been available to us anytime we have any kind of questions. They have been wonderful about answering phone calls. And I can't say enough about the ease of WoundRounds University. It's available to all the staff, and it does have the webinars, handouts, instruction sheets, and all of that, and that's really been instrumental in helping our staff get accustomed to this. If they have questions, if I'm not available, or if a key person is not available, they can jump on WoundRounds University and get an answer very quickly. So for us, again, it went remarkably well. I almost want to knock on wood when I say that, but it did go very well.
Thanks, Jennifer. Another question has come in about how you work with physicians and other consultants who are outside the facility who might need to play within the wound care process. How does your team do wound management outside your four walls?
Well, again, I've talked about the reports, and I do love those reports. And so what we see a lot with our facility, we are referral-based. So a lot of the physicians in our area, this is a more rural area, and we see a lot of those primary physicians that they do want to stay somewhat involved in their patients' care. They've seen a lot of these patients for years, and they want to keep up with them. So what we started to do is take our WoundRound report and go back weekly to that physician, the referring physician, and kind of give them an update. I mean, as you've seen, you've got all the information on there, you've got a picture, and our referring physicians loved it. They felt like they were a part of things. And of course, for us, it gives our liaison a chance to get in front of that physician. It gives them a good excuse. So for us, it really helped using that, and we continue to do that even now. We have a really good relationship with those physicians just because we're simply sharing information. That's it.
Sure. Thanks, Jennifer. Another question, and I think this came in response to your comments about litigation and meeting with an attorney.
Mm-hmm.
And this question is about the use of photographs of wounds, particularly in a legal or a courtroom setting. And she said her facility is hesitant to do wound photography for fear that those photos might be misrepresented in a courtroom. And I'm wondering if you have any experience to speak from regarding this situation.
Well, actually, that question was brought up when we first did roll out WoundRounds. One of our facilities did not take wound photos. They had that same concern. So as time marched on, we did roll out WoundRounds, and we did require that they go ahead and start taking those pictures. We felt like it would be a necessary thing. And they actually came back afterwards and said, you know what, thank the good Lord that we actually did take those pictures, because they were able to mitigate some really big harm by having those pictures. And again, just from my personal experience, I know probably at least 3 instances, personal experience, where we were able to go back maybe with a difficult family and show them the progression in the wound. So for us, I can't imagine not doing it. I don't know if that answers the question, but it's certainly been beneficial. And the one facility that we did have, again, the physicians were concerned about taking the pictures. It's ended up actually helping them in the long run. And we've seen no adverse outcomes because of it.
Thank you. Thank you for sharing that perspective. I know I've also heard as well that family members also have smartphones with camera capability. So sometimes not necessarily your own staff in the photos, but photos from family members as well. So what I wanted to do is ask if there are any more questions. I think that we've covered all of them here today. Oh, well, I hear one more question come in, and then we will ask Jennifer to wrap up and thank all of you for being online. But our last question, as I'm trying to read it and figure this out, is does your facility require a waiver to be signed to take the wound photo? And I was wondering how you handle that within your facility, Jennifer.
We cover that in our consent to treat. There is a line that is a consent to photograph, and we have it all rolled in with our consent to treat. And it is gone over with the patient or the patient's family, whoever's signing, that they are aware that we will be taking photos. So we have it all rolled into our consent to treat.
Okay. Well, that makes a lot of sense, and it seems to probably be a lot easier that way as well.
Well, we think so.
Well, Jennifer, I can't thank you enough for providing such an enlightening education for us all today. And for those of you who have been online, you see Jennifer's contact information here if you'd like to reach out to her. You will also be hearing from WoundRounds with a copy of today's handouts from today's webinar, and also a link for how to find this archived webinar online should you want to rewatch or share it with a colleague. But for now, I'd like to say thank you for joining us. I'm Deb Kurtz, and on behalf of WoundRounds, thank you today for participating in Technology for Improved Wound Management. Bye for now.